So here we are, NUR203, exam 3, your last exam. Next week is going to be your HESIs. As I was telling some of the earlier students, on next Saturday at 2 o'clock, I will be doing what I call a last chance all pediatric HESI review. And what I do is go over all the concepts and try to make you think and bring it all together. I have been told that it really helps bring all of those concepts together. So again, I'll be recording it. It'll be up on your walls. It's just something I started about a year ago, and it really has helped students. And that's why I continue it. And I do PN and RN for that because it's the same material. It's just a different viewpoint on it. So let's go ahead and let's start. I made a completely new slideshow for this, your study guide. And I did that just to make sure that as I looked through the exam and looked through the information, was it covered? Is it there? Is the concept appropriately addressed? And I can tell you now, absolutely, it is there the way it should be, okay? So one thing I want you to do is if I'm going over anything and you don't understand or you're not understanding my squeaky voice, please stop me. I do not get offended. It does not bother me. I want you to understand, okay? Now, this is a lot of chapters. Chapters 41, 45, and 46 through 49. So I did try to put it in the weeks of when you're getting this information. I went from week 7 and then I went up to last week's information and put it in here. Some things are off PowerPoints. Some things are PowerPoints. I added more stuff. So you'll see a little bit of similarities if you are using my PowerPoints because I make the PowerPoints for if your professor does use them. So head injuries. What do we know about head injuries? We know that kids fall off of bikes, that motor vehicle accidents, the biggest of injuries, and of course, sports injuries. And one of the things that we see is that children brought into the ER and they are, come in because they lost consciousness and the parents are really nervous. Well, it's because of that little sheer injury in the head. Now, what do we need to know about head injuries? Well, once you have a child who's come in with a head injury, the most important thing to monitor is the level of consciousness, because that's going to tell you if a child is getting more and more confused, right? One of the things is also headaches. And then not only the headaches telling you there's cerebral edema, and then vomiting. Now, we do check pupils on these children. It's one of the first things that we do on any head injury is just what medical staff does. We go and look at pupils right away. If they're fixed and dilated, we need to do something quick. It is an emergency. There's pressure being built up, and it could be a hematoma in the brain, okay? So what do you see with these children? You're going to be seeing them getting restless, increased headache. We're going to see them changing in level of consciousness. And these are telling you that we have to do something. So here we are, we're listing them down. So head injury, very important that we monitor these things. And again, that fixed dilated pupil, as I said, emergency, emergency. Now, there are times where infants do have traumatic brain injury. It could be at birth, or it could be that they fell off a changing table. I've seen all of them. It's hard to do a traumatic brain injury on an infant, but it happens. We're lucky with infants, we have that fontanelle. And if we start to see it getting bulging, we know pressure's building up there. And then those scalp veins also. This actually shows hydrocephalus too, that scalp veins coming out. Now, with the head injury that's traumatic, there could be blood again in the brain, and it pushes on the brain stem, which is the back of the head, and it pushes it hard, and it starts causing bradycardia. And that's why bradycardia, because usually it hurts, it's tachycardia. But when we start seeing bradycardia, we know it's something in there. Now, bacterial meningitis. Let's just go back to signs and symptoms of meningitis. We know it's the fever, the headache, the light sensitivity, the nuchal rigidity, yes. Now, is it viral or is it bacterial? They both have different treatments. Well, we know if you have something that we believe is meningitis, you better prepare. We're going to be doing a lumbar puncture, right? That is the treatment that we would do for it. Now, if it is bacterial, we're going to see low glucose, elevated white counts, and then proteins are increased because bacteria don't like it. They like sugar, so they eat it up. And that white look, we know in it is the white blood cells. It looks like milk that are bacterial. Make sure once we do that spinal tap that we have them lying flat for 30 minutes. It's just like getting a spinal that we would give for anesthesia. We're going to make sure that they're laying flat so we don't get that headache. Give them fluids and slowly raise their heads. Nobody wants a spinal headache. So once we do that tap and we come out, it's white and it doesn't look good. Number one, these children are vomiting. They don't feel good. Usually it's IV fluids, but priority is antibiotics. A bacteria in the brain is dangerous. So antibiotics, that's going to be priority. We're going to do cluster care, as in we're not going to go in there 10 times to do 10 different things. We'll go in and very slowly do what we have to do because that helps that stimulation and it will prevent seizures. And the biggest thing that we need to protect you and our other patients is droplet isolation, first 24 hours. Once they've been on antibiotics 24 hours, usually they're okay. Not to say they're going to be walking around the unit, but the droplet isolation, we don't have to be as prudent with it, okay? Now, when you have meningitis, we know one of the things that can happen is inflammation, and we could have cerebral edema. It could be due to trauma, or it could be due to a meningitis. Doesn't matter. Both of those things can cause fluid to build up in the head. So, how are we going to get rid of that fluid in the head? Well, the one thing that we'll do is give a diuretic. And the diuretic that's specific for the brain, for the head, is mannitol. Okay? Now, as we are treating these children, head injuries, meningitis, something that we know that there's fluid balance, there's too much in the brain, we're going to be monitoring intake and output. We don't want to increase the pressure by too much fluid overload. So a child with increased intracranial pressure, again, same type of thing as we would with head injury. Monitor LOC, lethargy, headaches, that vomiting. And then in infants, it's easy. Is there a bulging fontanelle? I mean, lethargy, you may or may not be able to tell with an infant because infants sleep a lot, but it's that fontanelle. So hydrocephalus is when there's water on the brain, right? Water on the brain has to do with the system that drains the fluid doesn't drain it the way that it should. Now, one of the words I found that even I had to go and look it up, so I've put your definition here, is masoenzyme. There is a difference between having water on the brain or an abscess. I guess it's the thickness of the fluids. And you tap on the skull and you can actually hear this resonant sound when there is either hydrocephalus or an abscess. So we can tell, do we have to, put a shunt in for hydrocephalus, or is it an infection? I mean, there's other things we can tell with your white cells and your CBCs, but that's just an instant telling. Another thing with hydrocephalus, as the pressure builds up, again, yes, you're going to have headaches, but how can a kid tell you that? Usually these are infants, but you're going to see the eyes changing shape the way that they look. And there's some good pictures in the book on it. It's called sun setting or setting sun eyes. And of course, increased pressure, always vomiting. Postoperatively, when you have VP shunts, we're going to be monitoring head circumference, and we're also going to be monitoring abdominal circumference because that fluid goes into the peritoneal cavity. We want to make sure how much is going in there. And of course, with any comatose child, adult, doesn't matter. The one thing, if they're unconscious, comatose, airway is always number one. Now, what can cause a seizure? I say almost anything, right? Infections, lesions, metabolic trauma, brain malformations, genetic, toxic, and we know just simple old fever. So almost anything could cause a seizure. Now, usually when we talk about seizures in children and we're giving questions on them, we're usually looking at that grand mal or that tonic-clonic seizure. And tonic-clonic seizures are something where all of the arms and legs are moving, they're foaming at the mouth, and risk for aspiration, right? So what do we do? Well, how do we take care of this? Well, if we go in and witness it, number one, look at your clock quickly because we want to know how long it's going on for. Documentation. Make sure you clear the area. Now, sometimes we can do it before and see sharp areas, but sometimes, kids, all the toys are in the bed with them, right? In the crib with them. So make sure we get rid of all those toys so they can't, when they're tonic-clonicking arms and legs, they can't hurt themselves. Put the side rails up. Many children that have history of seizures will already have pads on the side rails. But if not, I use pillows, blankets, whatever I have, and keep, so they don't bang on these side rails. Take that pillow out, put them flat, turn them over to the side. Now, suction's at the bedside, not to put in their mouth, but to suction as they vomit so the area where they're breathing is clear. Not in the mouth, but where that vomit went to, so they don't smush their face in it and then they can't breathe, right? And also, with these seizures that are continuing, we should make sure that we have an IV access. Some of these go into status epilepticus, right? Seizures, which means they don't stop. And we're going to have to be prepared to give them like diazepam or anti-seizure medications. So that IV is important. And again, these things we need to teach our parents. So pituitary dysfunction. When you talk about pituitary dysfunction, we talk about two lobes. The anterior is all about growth. And if we don't have enough growth, we know they're going to be getting a growth hormone. And it's really something that parents and children need to discuss because it needs a commitment, because they will be getting subcutaneous injections every day, just like insulin. So important that the parent and the child knows that. And we keep giving it until they stop growing. One of the things that we need to ask, though, is are people in your family normally short? Or is this child the only one short? Because if everybody's 5 foot nothing, this kid's not going to be more than 5 foot nothing. You can't have something grow that you don't have that hormone hereditary thing. They won't grow that much. Now, the other lobe is all about fluid balance, right? When we talk about fluid balance, we talk about diabetes insipidus, and we talk about the syndrome of anti-diuretic hormones. Now, diabetes insipidus, we are urinating, urinating, urinating drinking, 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 and you could stop them drinking and they're still going to be urinating, urinating. The key thing that we can find out with that infant, that young child, we could give them water in a bottle and they stop crying because they're sated by it. It satisfies their need, but milk does not. And that's usually the symptom that we start, oh, now let's look for diabetes insipidus on these children. Now, diabetes insipidus, we treat it again, fluid balance, anything with fluid balance. And we're going to go into some more. Intake, output, daily weights. Too much fluid being held up, salt restrictions, and we're going to be monitoring fluids always. This is part of fluid balance in children. Now, diabetes insipidus, we're going to do those things. We don't do fluid restrictions. We give the medications on this child. This will be the vasopressin. So in diabetes insipidus, intake, output, daily weights, we got to monitor what's going on, and we're going to replace that vasopressin. And remember, this is for life. It's not something we can cure. Now, the endocrine system. When we talk about the endocrine system, we always think number one, diabetes. Diabetes in children, we all have certain things that we see. Yes, the 3 Ps, polyphagia, because the carbohydrates aren't digested and they're hungry. So the body wants you to eat, eat, eat. Polyuria, urinating a lot, and polydipsia, drinking a lot. We're also going to see, because they're not eating carbohydrates, weight loss. And one of the things that's the symptom, sometimes bringing them in the quickest, is the enuresis nocturia. Bedwetting is one of the big red lights for diabetes in these children. Also, when you ever want to work newborn ICU, you get an infant of a diabetic mother, especially if they're post-term, they're more than 40 weeks. These children will have low blood sugars, and they really need close monitoring. Sometimes we don't even know if mommy is a diabetic, but it's usually these are large babies. These are your 10-pound babies that you'd be the most concerned about. One of the ways that we treat and look at diabetes is now measuring the hemoglobin A1C. And that hemoglobin A1C looks at the last 3 to 4 months of your blood sugars. Now, the number 7 is that beginning of diabetes in children. We know it's 6 for adults, so we give children a little bit more. Also, blood sugars. It's 100 in adults. It's 126. Why 126? I don't know. It's the number they chose. And that's where we start saying, that's a little bit high for a child. Now, hyperglycemia in the presence of ketonuria is diabetic ketoacidosis. So we have a child coming in with high glucose. We don't always assume it's a DKA. We're going to do a urine test, dip for those proteins. If we find proteins, now we know this is DKA and this is very life-threatening. I have seen blood glucoses of 1,000, and then the ketoacidosis or the metabolic acidosis, a pH of 6.8, which is really not, conducive to life. The child made it because they were there. We give what they're supposed to do. What do you do for diabetes? Fluid, dilute that sugar, and regular insulin drip on a slow, continuous infusion. And that's how we will manage those things. Now, as we get going on, into DKA, these children, they come in, they're pale. They can hardly hold their heads up. They're really lethargic. You can smell the sugar oozing through their pores. You really can. And it can cause hypotension bradycardia, but mostly it's that pale, that smell, and you can tell. And then of course they're, the decreased skin turgor, again, dehydration on these children. Now, the insulin management for children, children don't like to take a lot of injections or needles. So we do have NPH and regular insulins, and sometimes they have to be given the same time. I know it's something that you were taught in foundations, but remember, it's clear insulin before cloudy if you're going to double up your insulins. Now, hypoglycemia in children, again, all of this depends on the child's condition. If the child's awake and alert and telling you they don't feel good, they're jittery, they're sweaty, that's when you can give them stuff like anything with sugar. Honey is a great thing if they're over 1 years old, right? And usually the one who's complaining is going to be over 1 years old. But orange juice, sugar, hard candy. I mean, usually you don't see diabetes in the young kids, usually about 2 to 3 when you see them first starting to come in. Now, if the kid is unconscious, remember it is glucagon that we're going to be given, and that's going to raise their blood sugars very quickly. And that's diabetes for us. Adrenal. Now, we have too much, too little, right? Too much cortisol is called Cushing syndrome. It is uncommon, but it can happen. And especially more of your adolescent age, your older children, you would see this more. But I've seen it in some younger ones. I've actually seen it where these children have gotten too much steroids for whatever condition. It could be that rheumatoid arthritis, it could be lupus. Those things we give steroids for. So we see these big red ruddy cheeks on these children. We see them pudgy in the extremity, not the in the trunk and the abdomen, but their arms and their legs are skinny because there's a lot of protein wasting going on there. So that would be the difference, and there they are right there, the whole thing. And remember, steroids increases blood sugar, right? And poor wound healing. See how that concept has pulled right into Cushing syndrome. And these children do gain weight. Now, Addison is not enough cortisol or aldosterone. That's both things from the adrenal gland. It has to do with when it's hypoplastic, it's something to do with assigning sex to your child. They're neither a boy or a girl. I've seen one in my career. In a very early part of my career, I saw it, and I was so confused. I did a lot of reading on it, which all of you are going to do those things when you see these different diagnoses. But these children complain of hyponatremia, hyperkalemia. These are children that we have to assign a sex to, and forever, ever, ever will be placed on that hydrocortisone, that prednisone, and in periods of stress, etc., like any other type of immune thing, they're going to be needing extra doses of this stuff. So that is Addison, has to do with sex. Now, thyroid. Well, as I've said, thyroid is so similar to adults. What do you see with adults? What do you see with children? Well, they're all the same except in hypothyroidism. I'll go into that with the next slide. Now, hyperthyroid is too much thyroid hormone being delivered. Now, have you ever heard a person say, I'm overweight because I have a hypothyroid? My thyroid don't work, so I gain weight because everything is sluggish. Well, that is, the hypothyroid side. But hyperthyroid, these children are hyper, they're active, usually they're thinner. And one of the things we need to teach these children is the medications that they take. If they haven't had their thyroid glands removed or done an iodine ablation, these children will be on medications for life. These medications have side effects and they cause leukopenia. You might see sore throats, you might see fevers. These things need to be reported to the doctor. We treat it with glucocorticoids, a steroid. Okay. Now, hypothyroidism. The difference between adults and children is children need it for cognition. Children also need it to grow. Those are the two things that are different. Okay. So, with even adults, dry skin, puffiness, sparse hair, constipation, sleepiness, and there you are, mental decline, decelerated growth at both ends of that. Those are specifically children. That cold intolerance, all of those things you will see. Now, you have a child just diagnosed with hypothyroidism, and some are at birth and some are later on. A lot of times we catch hypothyroidism at birth. This is the one who shows constipation for the first 2 days of life, right? Hypothyroidism, cystic fibrosis, Hirschsprung's, those three things is constipation at birth, and they go looking for them. Sometimes it's a little bit later on that we see it, and we need to give them medications. And as nurses, we need to let parents know, give this medication in the morning. Because remember, thyroid hormone gets you up, gets you moving more, right? If we give it at night, this child's not going to sleep. Must give it in the morning, same time. Okay. Now, because of this constipation that we can correct, right? Extra fluids and fiber in their diet must be given to these children with thyroid dysfunction. And it's a picture for you. You can look at it. Now, vomiting. When you talk about vomiting in children, I always say you get an infant in and they tell me the symptom of vomiting. First question, is it dribbling or is it across the room? You could point it and get it in the garbage can 10 feet away. And that's projectile. And I'm telling you, they can go 10 feet away with projectile vomiting. It is actually quite impressive. These little 8-pound, 9-pound babies doing this. 3 weeks to 3 months is pyloric stenosis. We'll go into that later. But just regular vomiting due to intolerance to food, all right? One of the things whenever you're losing body fluids, vomiting, diarrhea, what do we need to look out for? Well, if you have an infant, a sunken fontanelle, that's telling you dehydrated, elevated heart rate, decreased blood pressure, absent or decreased urinary output, slow capillary refill. And infants, they cry. They don't have tears. I think that's the saddest thing, to see a little infant crying. Their eyes are sunken in and there's no tears coming out. And then skin tenting, and you can actually pull the skin and it will tent. So, what do we do for a child who is vomiting? Well, if they're still actively vomiting, we're not going to give them anything to drink. We will, and especially sunken fontanelle or really elevated heart rates, low blood pressures on older children, we need to get an IV in and we need to give them a bolus of fluid. Remember, when you're bolusing fluids, never give dextrose. Never bolus with a fluid with potassium. And once you've given that bolus and that child now needs a maintenance fluid, make sure you don't add potassium until the child voids or until you have a potassium level back. You could really harm the kidneys if you did it without, having a good potassium level back. Again, with vomiting, you always want suction around. And again, turning to the side, it's a constant thing that you're seeing. Now, sometimes that vomiting is just that dribble, right? That little dribble could be reflux, GERD. What you see with children, infants, they will be fed. You put them on your lap, you can feel them arch, and you know that they're refluxing. It's like, oh, this kid is refluxing. You'll be able to see that if you ever want to work in this area of children. So, how do we treat infants with this reflux? Well, you want to keep the food in the stomach. So you thicken it, and you thicken it with rice cereal. Now, they're not going to get the nutritional benefits from the rice cereal, but they're holding their milk down, which is what we want them to do. Never overfeed them. Make sure they're burped well. Have them sitting up um, after their meals. And in older children, you will see these kids, and this could be adults too. After you eat, all of a sudden you have this cough and then this heartburn. You can feel it. Older kids, adults, same thing. And how do we treat it? Again, no overfeeding, bland diet. And then the surgical type of intervention, if none medications work, diet, putting them on antacids like Pepsid, and then there's a handful of many different drugs we could put them on. If they don't work, they're going to do Nissan fundoplication. This Nissan fundoplication takes the stomach and picks it up so it can't put vomit up the esophagus. So it prevents vomiting. You'll see this in almost every person with a gastrostomy tube placement. They don't want that food to come up. They want to keep it down. And now you're projectile vomiting, pyloric stenosis. So now the family's told me it's across the room, and I'm going to tell them, okay, do not feed your child anything anymore. Usually these infants will get over to ultrasound, we'll diagnose it quickly, and then what we're going to do is just start an IV. And the IV is only to keep the fluids and their sugars, because infants do drop blood sugars quickly. And remember, 3 weeks to 3 months, these children is usually that age here. So remember, these kids, they're vomiting across the room. The next thing I do is take my hand and put it underneath that xiphoid process. And you will feel that olive or that marble, and you really can feel it. It's that thickened muscle on the pyloric sphincter at the end of the stomach, which goes into the small intestines. And what they do is they're going to go in and open it up. And postoperatively, we'll start fluid slowly. These kids do well. No long-term, usually, disabilities. Now, another thing could be things that have to do with nutrition. Well, when we talk about hepatitis, it's an inflammation of the liver. Well, what does the liver do? Well, we know with hepatitis, you always protect yourself, universal precautions. You're always washing your hands, gloves. That's just, what we do. Now, liver secretes bile. What does bile do? It digests fat. If you don't have enough bile to digest the fat, fat is lost, and you're going to see, these children are not getting enough nutrition. Just think about with nutrition, they taught you fat has 9 calories per gram, right? Carbohydrates and proteins are 4. So you're talking about a lot of calories not there. So if we give fat to these children, you're not digesting it, and it's going to bloat the stomach and cause a lot of pain, which we don't want to do. So to make up for that nutritional deficit, high protein, high carbohydrates, right? And that will replace the calories of the fat. And meat, fish, fruits, vegetables, milk, they're all good things. And I would actually do a 2% milk on these children because of the fat, right? Another nutritional thing is celiac disease, and it's an intolerance to gluten. Wheat, rye, barley, and oats, they don't tolerate it. And we know in children that they like their breaded chicken nuggets, macaroni and cheese, right? Peanut butter and jelly sandwich. Well, we have to do something different. Well, today they say rice is a good substitute. They have rice flour for everything today. And I've said it that today people are luckier. When we talk about nutrition, our grocery stores today have gluten-free stuff all over the place. We didn't have that 40 years ago. So it's something that nutrition has come to the forefront. It's easier to feed these children with celiac disease who becomes adults with celiac disease. Remember, it's lifelong. It doesn't stop. Now, food allergies. Well, we know we start feeding kids really slow, right? And we know that we're feeding them slow because we want to make sure there's no food allergies on these children. But think about what not feeding them that food can cause. For instance, and I have one example here, lactose intolerance. What is in milk? That's nutrition, vitamin D and calcium. If you're not getting vitamin D and calcium through the milk, these need to be watched or they need to be replaced in another way. Okay. And that was the purpose of the food allergy. Now, Hirschsprung's, megacolon, big type of distended bowel obstruction. And why? That area of descending bowel has no nerves. There's no peristalsis. It sits there and gets larger and larger and larger. And it doesn't hurt because there's no nerves. You might feel a distended bowel on palpitation, but the child doesn't feel the pain. You may see a little ribbon stools because the end of that anus, if you see, it's like this tube. It's like squirting frosting out of a piping on a cake, right? That ribbon, that's what it looks like. So how do we treat Hirschsprung's? Well, we're going to have to do either one or two things. Usually, we'll go through, we'll do that diagnosis, find out. We'll do an x ray to look first. We're definitely going to do a biopsy, looking to see if there's nerves in that intestines. And that confirms it right there. We'll either go ahead and put a colostomy because the stool has to go somewhere. It can't sit in the intestines and keep getting bigger. It will perforate, and we don't want that. So as soon as we can, we do a colostomy. And then usually within a year, they reconnect it. But they also can do what we call pull-through procedure. They remove that piece of intestines and then take the good part and connect it down to where the other good part is. And it's called a pull-through. It's one procedure all at once, never a colostomy. Now, nursing care of a child post Hirschsprung's, no rectal temperatures. We have touched that intestinal, tract. It's angry. Nothing to eat or drink for 2 to 3 days minimum. Let's let it rest. And then slowly we'll start with clear liquids. Now, enterobiasis. This is pinworms, something that kids do get. Signs and symptoms, it's they're itching like crazy and scratching, usually at night, because it's nice and dark and they're not moving around. So all of a sudden they come out to play, the pinworms, let's say. And all of those tickling down there, these kids aren't sleeping good because of it. So we need to get a worm for a diagnosis because there's many different types of worms that they could get. So we use a flashlight at night. We check the anal area, have a piece of scotch tape ready, stick it on the anus, and you're going to see that little pinworm there. And they are that tiny, but they create such havoc on these children. They're itchy, itchy, itchy. And if a child has it, check the whole family. It is contagious. And this is one of the reasons why, for many reasons, we tell you keep the child's nails short. Any sort of skin problems, right? Keep the nails short. Well, kids who like to go outside and play, keep the nails short. We don't want to have little pieces of something underneath, eggs, whatever, and then that will spread it around. Now, esophageal, tracheoesophageal fistula. Now, one of the things with this is there's no connection to the stomach. And the only connection there is is a connection between the esophagus and the trachea. So we know if there's an outlet for something to go in another place, like a
Word up.
shunting thing, we know that these children are going to swallow even their own mucus. It goes down the esophagus and right into the lungs. Many aspirations are happening. You can see that, right? Now, how do we figure this out? Well, many times these children, now they're born, they do have a lot of mucus in their mouth. We do a lot of suctioning right at birth on these children. They were floating around in mommy's amniotic fluids, right? So we suction it out. So we're not really looking at the gagging and coughing and choking yet. But as I said, infants don't like low blood sugars. And we tend to, the first feed, give them a little bit of sugar water to keep their blood sugars up. It's just what we do. And when we feed it, it's usually in the nursery when they take the baby to weigh it and all of that, wash it up, etc. That nurse sees this choking, gagging, just coughing up. That is the biggest symptoms of tracheoesophageal fistula. So, what we're concerned about here is airway. Even mucus that they're swallowing is going into their lungs. And it is something that we need to prevent aspirations as much as possible. So, what do? It's going to need surgical correction. But in the meantime, we got to keep these lungs from having all these mini aspirations, right? So elevate the head of the bed, suctions at the bedside, try to keep that mouth free from foaming and bubbling, right? NPO, nothing into the mouth because it will go directly into their lungs. They're going to get IV fluids because they can't eat or drink. They need fluids, they need their dextrose. And very important, this child is going to get antibiotics because of those mini aspirations to prevent pneumonias. In pyloric stenosis, we don't need antibiotics. That one's not having many aspirations. Tracheoesophageal fistulas are. They need that antibiotic because they are getting that fluid, that mini aspirations, that mucus into their lungs. And because children self soothe, right? Infants do. They explore the world through their mouths. They need to have that pacifier, a non nutritive sucking, because again, it's growth development, it's keeping them sucking for when we fix it, then they already know how to suck, right? On the pacifier. Because sucking, swallowing, and breathing is very difficult. That's all an infant has to do. But if they've never sucked, now they've got to learn it. So from the beginning, get that pacifier there. And it does help them self soothe. Now, acute appendicitis, right lower quadrant pain, McDurney point, yes, it is. And what we know about this is that this area between the small intestines and large intestines at the cecum, this appendix is, no, I don't like it. I want to come out. So the kid comes in, is in pain. We do an ultrasound, we diagnose it immediately. NPO. These children will become NPO. These children will get IVs started before surgery, and these will get antibiotics because of the possibility of it perforating before we get upstairs to the surgical room, right? Also, because children are on different medications for different reasons, we're going to be giving those pre-op medications. It may not be PO, but it could be IV if it's one of those necessary type of things. Now you have the child who's perforated. The pain stops right before they go to the OR, and you're like, oh, it's perforated. And you know it as a nurse. Postoperatively, think about that cecum, that appendix just burst, spewed, all of this really nasty material into the peritoneal cavity. And it's touched all the intestines, and the intestines are angry, right? So, how do we treat these children? Well, we want nothing in that intestines. We want NPO, but we want an NG tube down there for all the stomach acid and any other secretions. We want to keep that intestines quiet. We want it to relax. Now, of course, we're monitoring for hypokalemia, hyponatremia. There could be a lot of fluid coming out or not that much. Every child is different there. But IV fluids and antibiotics for these children because it's a raging peritonitis going on. We'll be monitoring, the lab works. We'll be monitoring the electrolytes. We'll be monitoring that white count. Is that white count coming down every day? And we should see that. Another thing is the peritoneal cavity is infected. And now we've done a wound closure, and that was two dirty areas put together. We need to be checking that wound. This is the wound that could possibly dehisce. So we need to watch it really closely. Another thing is because their abdomens are so tender, they need to be up, out of bed. They need to be walking. They need good pulmonary care. These children, be creative. A little kid will blow bubbles because they think it's fun, but you're actually helping them with their lungs. Or one of those pinwheels, have them blow it because we know it could be fun. I had an older child. She was 15, I believe, 14, 15. And she actually had a trach replacement. And I worked night shift. And we used to put up a target and we would do spitballs through a straw. And that really created PEEP in her lungs and it kept her lungs open and it worked. So be creative. Anything can be done. Now, an omphalocele gastroschisis, it's a birth defect where the insides are born on the out. Now, all that stuff in there works, is just on the outside. So we have to get it back in there, right? Now, we've got to keep it clean. We've got to keep it from getting infected. We need to keep the integrity of the tissue. And the insides are on the outside. We need to keep them warm. So these children at birth, we're going to put a sterile wet dressing on it to keep it moist and keep the sterile, okay? In a warmer, absolutely, keep them warm. These children will be on their back because that forces the stuff to go in the abdominal cavity. We are not going to swaddle these children. And because you have the insides on the outside, you want to keep them on antibiotics. It's just like having a fractured bone on the outside. You need antibiotics to prevent infections. And of course, they're not eating, nothing. Again, a pacifier and IV fluids. Meckel diverticulum, this is in the small intestines. And what we need to know about it is what we're going to see. These children will have some bleeding and they don't really feel any pain. Slight tenderness, maybe, right around the belly button. But this is something they have to go investigate it and they'll have to remove it surgically. Now, nephrotic syndrome. Nephrotic syndrome has nothing to do with renal failure. Nephrotic syndrome, your kidneys are working, but the kidneys are saying, protein, I don't like you, I'm getting rid of you. So what do you see? You're going to see all the protein lost through the urine. Remember, intravascularly, we have something called albumin, right? Albumin is protein. So in the blood, you're going to have that hypoalbuminemia. You're going to see massive proteinuria, protein in the urine, and it also affects the fat, so hyperlipidemia. Because of the change of the osmotic pressure intravascularly, fluids go out extracellular. So now you have generalized edema everywhere. So you are retaining fluid. Remember I told you about fluid? What do you do when you retain this fluid? It's going to be salt restriction, fluid restriction, intake, output, daily weights. Always fluid restriction when they're retaining it, okay? Now, glomerulonephritis. This is like rheumatic fever. It's a strep infection that we didn't treat completely, or it was just a sore throat, so they didn't get antibiotics. What do you see with glomerulonephritis? Well, nephritis, kidneys. All of a sudden, the kidneys stop urinating. They don't work. You start retaining fluid. This is when you see periorbital edema. Kidneys not working. What do you always think about kidneys not working? High blood pressure, right? High blood pressure causes what? Headaches. So if a kid is having big headaches, we really need to be monitoring that blood sugar, that blood pressure as much as possible. Kids can have a stroke from high blood pressure, okay? We're also going to see their urine is going to look red-brown in color. And yes, protein in the urine, because that's the kidneys not liking themselves, and it will secrete protein. Okay, glomerulonephritis, you're not urinating. What are we going to do? Low sodium, fluid restrictions, daily weights, I&O, and because it's kidneys in the peritoneal cavity, we're going to do abdominal girth measurements, right? And these children are just like the nephrotic syndrome. They are susceptible to infections. Now, renal biopsies are done when you're looking for a tumor or you're looking for an infection that can't find out what's going on. We need to go directly to the kidney and find out what's happening. Now, preoperatively, usually it's NPO for a certain amount of time and they go to the procedure. In children, they will be giving them sedation because it's, putting a needle in their back. And in infants, they even cut a little incision to find the kidneys because it's a little area there. Now, when they come back is what we need to look at. And it's very similar to cardiac cath. So you come back, there you need to take their vital signs for sure, but you need to be looking at that dressing. So you've stuck a needle into a kidney, so you could have urine leaking. You stuck it into a kidney, you could have bleeding. And remember, that could also go into the peritoneal cavity, urine or blood, which will irritate it. So you're going to be checking for tenderness in the belly, right? These children will be on bed rest 24 hours a day. They can eat, they can drink once they're woken up and they're fine, but bed rest. We don't want it to dislodge the clot, which is holding urine and blood, back where it needs to be. Renal failure, it could be at birth. It could happen later on, but in the management of this, let's say they're born with a congenital problem and they're in renal failure. Well, an older child can have hemodialysis, like the picture on top. And the older kids, they tolerate it well. And just like adults, we're going to maintain the function as good as we can. And of course, maintaining fluid electrolyte balance. Those are always your goals in kidney failure. Because the kidneys aren't working well, they're not producing erythropoietin, we're going to be giving erythropoietin to these children so that they're making more red blood cells to decrease the amount of blood transfusions. And any disease in kids, you want them to be as normal as possible. I mean, when you're on chronic renal failure, you are on a machine 3, 4 times a week. So, I used to see some wonderful things in the hemodialysis unit where I worked. They'd be having music day, they'd bring instruments in, or they'd be quilting, or they'd be doing, making books to show other children, writing about their experiences. And they did a lot with them to keep them feeling normal in many different ways. Now, peritoneal dialysis must be done on your younger children. It is something that's done at home, and that's what parents like. They don't have to go anywhere. They're taught how to work with that catheter right there, and that looks just like a peritoneal dialysis catheter. And in sterile technique, we're going to take a big bag of fluid and have it on a warmer. And it comes down through tubing and it inserts a certain quantity of fluid inside the peritoneal cavity, and that works as your kidney. We let it sit there for some period of time, 20 minutes, 30 minutes, depends on the nephrologist who's ordered it. And then we let it drain into usually a Foley catheter bag. At the end of the night, we could have done 8 or 10 cycles because we do this at night when the kid's sleeping. It's the best time. We will look at how much fluid we put in and how much is there, and that's your output. So it works good and we can measure it. Now, all you have is a peritoneal cavity for dialysis. If we let peritonitis occur, we don't have a kidney. That is basically a death sentence for these children. So what do we as nurses need to look for? Any change in color or any change in the consistency of fluid, we need to call the doctor, the healthcare provider, immediately so he can order antibiotics. We need to save that peritoneal cavity. Scoliosis is an S-shaped curvature. When we talk about the S shape, it could be minimal, 25%, and then it could go up to 55%. But they say between 25 to 45, we're going to do, and it's usually at that pre-adolescent growth spurt time. So these are those adolescents with body image things that are going on, right? And they have to wear this brace 23 hours a day. And they must be in physical therapy. And it strengthens the muscles to hold that spine in the way that we're trying to get it back to. Underneath these braces, we're going to have a cotton t-shirt. They actually say white is the best, no colors, no lotion, no powder, no. Because that lotion can cause, bacteria to grow, and then the powder can clump, creating other problems. So, just dry off, of course, deodorant, yes, but we want to keep it as clean and dry as possible. Now, if it is greater than 45 degrees, and this is actually, the S shape is actually impinging upon one of the lungs, the cavities gets really small. So we've got to straighten it up so you have the best respiratory that you can, because you're squishing a lung, it can't expand. So they'll do surgery. The newest thing to do is the spinal fusion, but Harrington rods, Luque rods are another one that they have done. It could be any one of them. Another thing that we use a brace for is developmental dysplasia of the hip. This is when that femur socket bone doesn't go up into the hip. It goes above somewhere, any level here. So you can see that one leg is going to be shorter. That's usually the first thing that we do see. We're going to see those gluteal folds, one is higher. We're going to see that positive Ortolani and that Barlow test. We're going to hear that clicking that's going on there. So we're going to put them again with a cotton t-shirt underneath, Pavlik harness on top, causes abduction of the hip, and 23 hours a day. Again, we don't want lotion underneath, but an infant can't tell us if there's some rubbing areas. We need to inspect the area, check for breakdown, and then just massage the areas. I'm not saying with lotion, just massage it, increase the circulation there. That 1 hour that they're off, probably taking their bath, right? And now we have fractures. Simple, the normal ones. They break it, we put on a cast, and usually there's hardly any manipulation. We just want to hold it straight. Opener compound is bone is through the going through the skin. Anything from the inside on the outside needs IV antibiotics. If we do not get IV antibiotics on these children, most likely it is going to be causing osteomyelitis. So we have to be really, really careful with that. Complicated, bunch of little different bone fragments. Many times it can go ahead and get another organ. For instance, usually fractured ribs can go and puncture lungs. It's the one that I think of. And then comminuted is little pieces that are there, and we've got to go surgical and we got to take it out because they are hard, they're sharp, and they cause spasms, muscle pain in the nerves. And then avulsion is when the bone just comes away from the tendon or ligament, which means there's nothing to attach, means there's no movement that could go on. With an avulsion, surgery will be needed. Now, types of traction. We have Buck's traction. We use it for fractured femurs. Always remember with fractured femurs, we're always checking pulses, movement, pain, paresthesia, all of the P's, right? We're going to be looking for that. Always make sure with any traction, weights are hanging freely. We never take them off, not for a bath, not for anything, because we have that femur end to end. And if we take off the weight, it could go like that. And now you're in severe pain again. We want to keep those end to ends as much as possible. Now, Russell's traction is just like Buck's, but it has an extra piece there, holding that area where the femur is. I've mostly seen Buck's traction used. I have seen Buck's once. Then we have some of the, skeletal ones that can go, they're metal into usually the head, cervical, Gardner Wells. And then there's Bryant's. Now, Bryant's is after Pavlik harness doesn't work. It's still a hip dysplasia. And we need to figure out another way to get that hip back to where it needs to go. And we can use Bryant's up to 30 pounds. It elevates the hip slightly off the bed. And then if you notice, it's a 90-degree angle, the feet up to the body. And again, it's the weights that are hanging freely there. There's all your P's that you always need to be looking for. Very important concept that we teach this to our parents too. Pain, pallor, pulselessness, paresthesia, paralysis, pressure, and cast care. I've said I've seen kids go home after a cast, put on their bathing suit and jump in the pool, and have to turn around and come back to the hospital. And not once, I've seen one kid do it 2 days in a row. I guess they just wanted to go swimming that bad. But we need to keep it dry. Underneath, it could grow algae and fungus, and actually, it's very dangerous to have them wet. Now, keep those fingers and toes wiggling. That helps with circulation. No lotion, no powder. They love to pour powder down there or take lotion and massage down there, sticking pencils and hangers. Nothing inside of them. Now, if it itches, they say a cool hair dryer, blowing down there, and that can relieve the itch. Now, cerebral palsy, there are definitions that we use for it. It is impaired muscle movement, poor posture, okay? And it causes hypertonicity, and that's your spastic one, where that hypertonicity on the children. So spastic is hypertonicity with poor posture, impaired muscle movement, difficulty maintaining balance. We know that treatment for cerebral palsy is speech, physical, occupational therapy as soon as we can figure it out. Teaching parents, keeping good dental hygiene, right? They don't, they're on, usually they have epilepsy. Many of these children do. So they're on the anti-epileptics like phenytoin, gingival hyperplasia, right? Keep those teeth brushed very, very well. One of the safety precautions with these children is they don't chew and swallow like, quote, normal children. Remember, poor muscle control, right? So give them time to chew and swallow. Also, do not try to feed a kid with cerebral palsy laying down, having them sit up a minimum of 45 degrees, and keep them entertained. I've always said my little Jonathan, where I used to do clinicals, that little boy, we did some really crazy things with him. We took him out of the wheelchair, put him in a pool of water and had water squirting everywhere. And if you could see that smile on that kid's face, I mean, you do those things, these kids do understand more than you think. Remember, there's always dosage calculations on these things. There's a couple of my videos there. If you want the worksheets, don't have them already, let me know. I'll send them to you. There are the Kahoots for this week. I know you can do it. Thank you for being patient and waiting for me to get back and do this review. I'm sorry you still got a scratchy voice, but I did the best I could for you. So I wish you the best.
Thank you.
My pleasure.
Thank you.
Thank you.